Welcome to the deep dive. If you're prepping for the MSRA, you know some topics are just, well, crucial.
Absolutely.
And today, we're really focusing in on one of those, primary sclerosing cholangitis, PSC. Look, medical revision can feel totally overwhelming, like trying to drink from a fire hose, right?
Definitely.
So our goal today, in this deep dive, is really to give you that clear, high-yield understanding of PSC. We're pulling out the essentials from the notes, so you can feel confident heading into the exam.
That's the plan. We'll cover everything, definition, causes, right through to management and complications.
Exactly. Your streamlined guide to nailing PSC for the MSRA.
So let's dive straight in, the basics first. What is primary sclerosing cholangitis?
Okay.
Well, put simply, it's a chronic, long-term liver disease. The issue is with the bile ducts.
The tubes carrying bile out of the liver.
Precisely. They become inflamed. And this isn't just a one-off inflammation, it's ongoing.
Right.
Which leads to scarring. We call that fibrosis. And because of that scarring, the ducts start to narrow, they get constricted, and eventually they can get blocked up.
So it messes with the liver's drainage system, essentially.
You've got it. And a bit more detail, it's seen as an immune-mediated cholestatic disease.
Okay, break that down a bit. Immune-mediated.
It means the body's own immune system seems to be mistakenly attacking those bile ducts. That's what kicks off the inflammation.
And cholestatic.
That refers to the slowing or stopping of bile flow, cholestasis. So you get the immune attack, inflammation, the narrowing, we call those strictures, the bile backing up, that's the cholestasis, and then the fibrosis.
And eventually this can lead to pretty serious problems.
Yes, unfortunately, over time, this whole process can lead to liver failure. So the key takeaways for the definition are inflammation, fibrosis, narrowing bile duct obstruction, and then immune system involvement.
Got it. Clear definition. So the big question then is why? What actually causes PSC?
Yeah, that's still the million-dollar question, really. The exact cause isn't known. Still unknown.
But the thinking is it's likely a mix of things, probably a genetic predisposition. Some people are just more susceptible genetically.
Right.
Then there's definitely immune system dysregulation involved. It's not working quite right. And probably some environmental factors too, though we're still figuring out what those triggers might be.
So like a perfect storm scenario, genes, immune system, environment.
Exactly. And it seems to be a combination. There's quite a bit of research looking into things like the gut microbiome and specific genes, that whole gut-liver axis idea, trying to pin down those triggers.
Interesting. So if the cause is complex, are there known risk factors? Who should we particularly think about PSC in, especially for the MSRA?
Yes, absolutely. There are some very clear risk factors. First off, it's more common in males.
Okay.
Second, it tends to hit young to middle-aged adults. Think typically between, say, 30 and 60 years old.
Right.
But the really big one, the one you absolutely must remember for exams, is the link with inflammatory bowel disease.
Yes, specifically ulcerative colitis, UC. The association is incredibly strong.
How strong are we talking?
Well, something like 4% of people with UC also get PSC. But look at it the other way around. A massive 80% of people diagnosed with PSC also have UC.
80%. Wow, that's huge. That's a key link to recall.
Definitely. If you remember one association, make it that one.
Is there any idea why that link exists, even if the main cause is unknown?
That's a good question. We don't know for sure, but theories involve maybe shared genetics or similar immune pathways going wrong in both the gut and the bile ducts. That gut-liver axis idea comes up again. Maybe inflammation in the gut triggers something in the liver's bile ducts in people who are susceptible.
Fascinating stuff.
Yeah.
Any other risk factors besides UC?
Yeah, less commonly, you sometimes see it linked with Crohn's disease, which is another type of IBD, and also sometimes with HIV.
Okay.
But honestly, for revision, focus hard on that UC connection. Quick memory tip. Picture a young to middle-aged man with UC. That's your classic profile where PSC should be high on your list of possibilities.
Young man, UC. Think PSC.
Got it.
That's helpful. Okay, let's dig into the pathophysiology a bit more. What's actually happening inside those bile ducts?
So the core process is that chronic inflammation we mentioned. It affects the ducts both inside the liver, the intrahepatic ones, and the larger ones outside, the extrahepatic ducts.
Okay, so inflammation everywhere in the system.
Pretty much. And this constant inflammation triggers fibrosis, the scarring, and that scarring leads to those strictures, the narrowings that block the bile flow.
Right, the blockages.
And remember, the immune system is driving this. It's not just simple inflammation. It's like the body's defenses are misdirected and actually damaging the ducts.
So the repair mechanism kind of backfires.
That's a pretty good analogy, yeah. The constant attempt to heal leads to excessive scarring, which then causes the blockage, like patching a road until it becomes too narrow to use.
This sounds like it could look like other liver problems. So differentiating it must be important. What else could it be? What are the differentials?
Absolutely critical clinically and for exams. The list of differentials is quite long, so breaking it down helps. So we could maybe use a mnemonic like vitamin B loosely.
Vitamin B. Let's try it. V.
V for vascular, things like hepatic artery thrombosis or issues related to portal hypertension affecting the bile ducts, portal cavernoma cholangiopathy, even things like intra-arterial chemo can sometimes cause similar changes.
Right.
Infections, think AIDS-related cholangiopathy, or maybe recurrent bacterial infections, recurrent pyogenic cholangitis.
Okay.
Trauma, maybe damage after gallbladder surgery, a
Yeah.
cholecystectomy, or other abdominal trauma.
A.
Autoimmune, this is a big category. There's autoimmune sclerosing cholangitis, which sounds similar. IG4-related sclerosing cholangitis.
IG4.
Yeah, it's a specific type of antibody involved in some autoimmune conditions. And also systemic vasculitis can sometimes affect bile ducts.
Huh?
M could be malignancy, specifically cholangiocarcinoma bile duct cancer, which is a major concern with PSC, but also a differential for the initial presentation. Or maybe metabolic. Idiopathic, meaning we don't know the cause, like PSC itself, but we need to rule out other specific idiopathic causes, or iatrogenic caused by medical treatment, like issues seen in critically ill patients or related to TPN, total parenteral nutrition.
Can be.
Benign conditions. The main one there would be bile duct stones, intraductal stone disease.
Wow. Okay. The vitamin B framework definitely helps structure that list. Thanks. Now, thinking about how common this is, what's the epidemiology like, particularly here in the UK?
Yeah, in the UK, it's considered relatively rare, but it has a significant impact. As we said, more common in men. Average age at diagnosis is around 35. Prevalence is estimated somewhere between, say, 8 to 15 cases per 100,000 people.
So not super common, but not vanishingly rare either.
Exactly. And the prognosis, unfortunately, the median life expectancy is around 12 years after diagnosis, which underlines its severity.
Yeah.
And it accounts for a significant chunk, about 10% of all UK liver transplants.
10% of transplants.
Yeah, exactly. 10% of liver transplants here in the UK, which really highlights its role in end-stage liver disease. And again, remember those key UK associations, IBD, especially UC, and that increased risk of bile duct and colorectal cancers.
Got it. Serious implications.
Right.
So moving on to how patients actually present, what are the clinical features we should look out for?
It can be quite variable. Some people are actually asymptomatic when diagnosed.
Really? Found incidentally.
Often, yeah. Maybe on routine blood tests showing odd liver enzymes. But when symptoms do occur, fatigue is really common, often quite profound. Pruritus, that intense itching, is another hallmark.
That sounds awful.
It can be debilitating. Jaundice, the yellowing, can occur. Hepatomegaly, an enlarged liver, might be found on examination. And some patients get episodes of cholangitis bile duct infections.
What does cholangitis look like?
Typically fever, maybe chills, abdominal pain, often in the right upper quadrant, alongside worsening jaundice or itching.
Okay. And as the disease progresses?
You might see more persistent right upper quadrant pain, maybe unintentional weight loss, worsening fatigue.
And on physical exam, what might we find?
Well, besides potentially hepatomegaly and jaundice, you might see scratch marks, excoriations from the pruritus. Weight loss could be apparent. And you'd also be looking for signs of the potential complications.
Oh.
Signs of liver failure like ascites, which is fluid in the belly, or confusion from hepatic encephalopathy. You also need to think about metabolic bone disease risk and nutritional deficiencies.
You mentioned assessing severity earlier. There's a scale for that.
Yes, the Child-Charcot-Pugh score, or Child-Pugh score, it's used widely in liver disease to assess severity. It looks at things like encephalopathy grade, ascites, bilirubin levels, albumin levels, and clotting time, the prothrombin time. Gives you a score to grade the severity.
Okay, useful for staging. So we suspect PSC based on the history and exam. What investigations do we order to confirm it?
Right. Investigations are crucial. We usually start with blood tests. The absolute key finding you're looking for is a cholestatic picture and the liver function tests.
Cholestatic meaning?
meaning raised alkaline phosphatase, the ALP, and often raised gamma-GT, the GGT. These point towards a problem with bile flow.
Okay, ALP and GGT are the main ones.
Definitely. You might also see raised transaminases like ALT and AST, but the ALP-GGT rise is usually more prominent. Bilirubin can be normal early on, but tends to rise as the disease progresses.
Any other blood tests?
You might check immunoglobulin levels. IgG and IgM can sometimes be raised. And certain autoantibodies, like PANCA, might be positive in maybe 60–80% of cases, but it's not specific just to PSC.
Right, so bloods give clues, point towards cholestasis. What about actually seeing the bile ducts? Imaging must be key.
Absolutely essential. An initial ultrasound is often done just to get a basic look at the liver, gallbladder, and check for obvious duct dilation or stones, but it often misses the subtler changes of PSC.
So it's better.
The gold standard for diagnosis is MRCP, magnetic resonance cholangiopancreatography.
MRCP.
Yes. It's non-invasive, uses MRI, and gives really detailed pictures of the bile ducts, both inside and outside the liver. It can show those characteristic strictures, the narrowings, and the little dilated segments between them, often described as having a beaded appearance.
Beaded appearance, okay. What about ERCP?
Endoscopic retrograde cholangiopancreatography. That involves passing an endoscope down to the opening of the bile duct in the duodenum and injecting dye. It gives great images, too, and crucially, allows for intervention.
Intervention
Like taking brushings for cytology to look for cancer cells, taking biopsies, dilating strictures with a balloon, or placing stents to keep ducts open. But because it's invasive and carries risks like pancreatitis, it's generally reserved for when you need to do something, not just for diagnosis. MRCP is preferred for the initial diagnosis.
Got it. MRCP for diagnosis, ERCP for therapy. Is liver biopsy always needed?
Not always for diagnosis if the MRCP findings are typical, especially in someone with UC. But a liver biopsy can be really helpful for staging the degree of fibrosis and inflammation. Yeah, there are histological stages, usually 1 to 4. Stage 1 is early inflammation around the portal tracts. Stage 2 shows more fibrosis spreading out. Stage 3 involves bridging fibrosis connecting portal tracts. And stage 4 is cirrhosis, end-stage scarring.
Okay, so biopsy helps assess severity and progression.
Exactly. And it can also help rule out other overlapping conditions, like autoimmune hepatitis sometimes.
So, summing up investigations. Bloods showing cholestasis, high ALP-GGT, confirm with MRCP showing beaded ducts, and maybe a biopsy for staging and ruling out other things.
That's a perfect summary. The goal is diagnose, stage, and exclude alternatives. MRCP is your key diagnostic tool here.
Right. Diagnosis confirmed. What now? How do we manage PSC?
Management is multifaceted. The main aims are relieving symptoms, managing complications as they pop up, and importantly, screening for liver cancer because of that increased risk.
Is there a cure?
Unfortunately, no medical cure currently exists for PSC itself. For patients who develop end-stage liver disease or have uncontrollable complications, liver transplantation is the only life-prolonging treatment.
Okay, transplant is the ultimate option for severe disease.
Oh.
What about managing those symptoms day to day, like the itching?
Yes, pruritus can be really tough. First-line treatment is usually cholestyramine.
How does that work?
It's a bile acid sequestrant. It binds bile acids in the intestine so they get excreted, which can sometimes reduce the itching signals.
Okay, if that doesn't work.
Other options include rifampicin, naltrexone, which is an opioid antagonist, and sometimes SSRIs like sertraline can help, though the mechanisms aren't fully clear.
And nutrition.
Very important, especially in children. Ensuring adequate calorie intake and managing fat-soluble vitamin deficiencies, A, D, E, K, is crucial because bile is needed for their absorption.
Right. What about slowing the disease itself down? Any meds for that?
This is the disappointing part, really. Things like corticosteroids or penicillamine have been tried in the past but showed no benefit.
Okay.
There's a medication called ursodeoxycholic acid, UDCA. It's a naturally occurring bile acid. It does often improve the liver enzyme levels on blood tests.
So it helps the numbers look better.
Yes, but unfortunately, large studies haven't shown it clearly improves long-term outcomes like survival or delaying the need for transplants, especially at higher doses, which were linked to worse outcomes in one trial. So its routine use is generally not recommended, though some centers might use lower doses for specific reasons.
Okay. So no magic bullet drug yet. Anything else patients should do?
Absolutely avoid alcohol. It puts extra strain on the liver and might increase the risk of cholangiocarcinoma even further.
Good point. What about interventions directly on the bile ducts? You mentioned ERCP earlier.
Yes. If a patient has a dominant stricture, a particularly tight narrowing, often in the large ducts outside the liver that's causing significant symptoms like recurrent cholangitis or worsening jaundice, then ERCP can be used.
To do what?
To perform balloon dilatation, basically stretching the narrowed segment open and sometimes placing a temporary plastic stent to help keep it open and allow bile to drain better.
Does that change the long-term course?
It can definitely help relieve symptoms and treat episodes of blockage or infection, but it doesn't seem to significantly alter the overall progression of the underlying disease process throughout the liver. Major surgical drainage procedures are rarely done now for the same reason.
So ERCP for troublesome dominant strictures, and then liver transplant is the option for.
For intractable, debilitating pruritus that doesn't respond to medication, for recurrent, severe cholangitis that can't be controlled, or when the liver starts to fail end-stage liver disease with complications like ascites, encephalopathy, or poor synthetic function.
Okay. Are there emergencies we need to watch for?
Definitely bacterial cholangitis, that infection in the bile ducts.
How does that present again?
Classically, Charcot's triad, fever, jaundice, and right upper quadrant pain. Though not everyone gets all three. They might have chills, feel generally unwell.
Yeah, that's serious.
Very serious. Needs urgent hospital admission, broad-spectrum intravenous antibiotics, and often urgent biliary decompression via ERCP to drain the infected bile. Prompt treatment is vital to reduce mortality.
Okay. Urgent antibiotics and ERCP for cholangitis. So thinking about prescribing overall, it's mostly symptom management.
Largely, yes. Lifestyle first, no alcohol, then meds for symptoms. Cholestyramine first for itching. For bone health, which can suffer due to chronic liver disease and potential vitamin D issues, calcium and vitamin D supplements are standard.
What about osteoporosis?
If they develop hepatic osteodystrophy leading to osteoporosis, then bisphosphonates might be needed. HRT could be considered in postmenopausal women too.
Right.
Antibiotics for any cholangitis episodes, as we said. And supplementing fat-soluble vitamins A, D, E, K if levels are low or there's evidence of deficiency.
Corticosteroids, immunosuppressants.
Generally not used for classic PSC unless there's a specific diagnosis of an overlap syndrome with autoimmune hepatitis where the features of both conditions are present. Then they might be considered.
And UDCA generally not recommended routinely.
Correct.
Okay. And the main non-prescribing management is really liver transplant.
That's the definitive treatment for advanced disease, yes. Survival post-transplant is pretty good, around 70% at 10 years.
And the indications, again, were severe symptoms or liver failure.
Exactly. Severe pruritus, recurrent cholangitis, or end-stage liver disease, and ERCP with dilation for those problematic dominant strictures if symptoms aren't controlled otherwise.
So putting it all together, what's the overall prognosis for someone diagnosed with PSC?
Well, it is a progressive disease. The inflammation and scarring tend to worsen over time. The prognosis is significantly impacted by the development of complications.
Which are?
Cirrhosis, portal hypertension, and its consequences like bleeding from varices, those recurrent bile duct infections, and critically, that increased risk of cholangiocarcinoma.
Is the prognosis the same for everyone?
Not quite. There's a subtype called small duct PSC, where only the tiny ducts inside the liver seem tested on imaging like MRCP, though the liver biopsy might show similar changes. These patients generally have a better prognosis and a lower risk of developing cholangiocarcinoma compared to those with large duct PSC affecting the bigger bile ducts.
That's interesting. And after transplant?
Post-transplant survival is good, as we said, 94% at 1 year, maybe 86% at 5 years, 70% at 10 years. But the disease can actually recur in the transplanted liver, happens in about 20% of cases over time.
Wow, okay. And just briefly, how does this differ from PBC, primary biliary cholangitis? They sound similar.
Good point to clarify for exams. Key differences. PBC is overwhelmingly seen in women, whereas PSC is more common in men. PBC has a very strong association with antimitochondrial antibodies, AMA, which are usually negative in PSC. PSC has that strong link to IBD-UC, which PBC doesn't.
And the location?
PBC primarily affects the small microscopic bile ducts within the liver. PSC typically involves inflammation and fibrosis in both the small intrahepatic ducts and the larger intra and extrahepatic ducts. So different demographics, different associations, slightly different targets within the biliary system.
Okay, that distinction is clear. So finally, let's recap the main complications of PSC we need to be aware of.
Right, let's group them. First, biliary complications. Things like bile duct obstruction from stones or dominant strictures needing ERCP or drainage. And bacterial cholangitis, needing antibiotics.
Second.
Complications of cirrhosis if it develops. That includes ascites, portal hypertension leading to varices, hepatic encephalopathy, and ultimately liver failure. Liver transplant is the treatment here.
And third.
The related cancers. This is crucial. There's a significantly increased risk of cholangiocarcinoma, the bile duct cancer, and also colorectal cancer, especially if they have underlying ulcerative colitis.
Which leads us to screening. What are the recommendations again? High yield for MSRA.
Definitely high yield. Okay, so any patient newly diagnosed with PSC should have a full colonoscopy with biopsies to check for IBD, even if they have no bowel symptoms.
Right.
If they do have known colitis associated with their PSC, they need annual surveillance colonoscopies from the time the PSC is diagnosed because their colorectal cancer risk is particularly high.
Annual colonoscopy for PSC with colitis. Got it. Anything else?
There's also often surveillance for gallbladder abnormalities like polyps, which are more common in PSC and can sometimes be pre-malignant. So annual abdominal ultrasound is often recommended for gallbladder surveillance.
Okay, colonoscopy plus annual surveillance and gallbladder ultrasound surveillance. Key points.
Absolutely.
Right, well, that brings us toward the end of this deep dive on primary sclerosing cholangitis. It's definitely a complex area, but hopefully breaking it down like this gives you a solid, high-yield foundation for your MSRA revision.
We've covered the key ground, what it is, who gets it, why it happens, how it presents, how we investigate and manage it, and what to watch out for.
Remember that really strong link with ulcerative colitis. Always keep PSC in mind with liver abnormalities in a patient with IBD, especially that young to middle-aged male demographic.
Good take-home message.
Now here's something to think about further. Consider how that strong association with ulcerative colitis might influence your clinical reasoning or management approach when you encounter a patient presenting with new liver function test abnormalities. How does knowing about the UC change things?
Yeah, food for thought there.
And of course, for loads more fantastic MSRA revision resources, practice questions, and detailed notes, make sure you check out pasttheMSRA.com.
And don't forget freemasray.com for valuable free content, too.
We hope this has been helpful. Best luck with your exam preparation. Thanks for joining us on The Deep Dive.